Hello and good day to one and all, and a warm welcome from Sankara Academy of Vision. On the occasion of World Cancer Day, we are holding a series of talks on ocular malignancies, and this is a part of the series which highlights upon the orbital and lid tumors and their management. It's going to be a broad outline on how things are going to be done. And we're going to follow that up with a talk by one of our ocularists who's going to talk about how we're going to rehabilitate patients once the socket is empty. Now, it gives me great pleasure to introduce the speakers today. We have with us Dr. Akshay Nair, who's a dynamic and young budding ocular, ocular oncologist and oculoplastic surgeon who is based out of Mumbai and is attached with Aditya Jyot Eye Hospital and also with the Shankara Eye Hospital at Panvel in Mumbai. So without much delay, I just want to hand over the podium to Dr. Akshay to take over the proceedings. Over to you, Dr. Akshay.
I'd like to thank the Shankara Academy of Vision for this opportunity to speak to you today on World Cancer Day about eyelid tumors. Given that this talk is aimed at residents and postgraduates, my talk will focus only on the primarily common tumors seen in our clinical practice. Now, even though eyelids comprise of less than 2% of the entire skin surface area of the body, they account for nearly 10% of all cutaneous tumors. And literature from the West tells us that the most common tumor is basal cell, followed by squamous cell, sebaceous gland carcinoma, and the least being malignant melanoma. However, this is not the case in the Indian subcontinent and China, where sebaceous gland carcinoma remains the most common eyelid tumor. As we would expect, each of the components that make up the tissue of the eyelid can have a potential tumor arising from it, which is why we have vascular tumors, epithelial tumors, mesenchymal, melanocytic, lymphoreticular tumors, as well as rare nervous tissue tumors, metastatic tumors, and developmental tumors. Common conditions or benign tumors are also known to occur, and similarly, they have a malignant counterpart as well. So it's important to know about them. We'll be focusing primarily on these tumors and understanding the clinical appearance and the treatment strategies for each of them. Now let us look at this tumor. Now here what we can see is that it's close to the lateral canthus, it's slightly elevated on the surroundings. We can see ulceration in the center, and there is slight pigmentation surrounding it as well. There's a nodular component as well as a central ulcerative component. Similarly, there's another tumor here. Now, this is also close to the lateral canthus. Now, what you have is an elevated lesion, which is thick, nodular, deeply pigmented with focal areas of ulceration. Both of these are variants of basal cell carcinoma, first being a nodular ulcerative and the second being nodular. But as you can see, there can be a crossover of clinical features which is seen in these kind of tumors. Other rarer tumors of rarer forms of basal cell carcinoma include morpheoform or diffuse, pigmented, cystic, and superficial variants. Now, similarly here, you can see that there is a nodular thickening, but it's primarily ulcerative here in the center. Loss of lashes is seen, and there is pigmentation surrounding it, another variant of basal cell carcinoma. This is a picture courtesy Dr. Swati Kaliki of LVPI. Now, this is a child with xeroderma pigmentosa, And a closer look shows that there is an eyelid tumor over here. Again, deeply pigmented, elevated nodular component in the surroundings, central excavation with ulceration seen in the center. Now, in xeroderma pigmentosa, which is an autosomal recessive condition, the additional UV light exposure, along with the inborn defective DNA repair mechanism, makes them predisposing to conditions like squamous cell carcinoma, malignant melanomas, and basal cell carcinomas. In fact, we've seen patients with all three coexisting tumors in the same eyelid. Patients with XP in the initial stage show freckles and scaling of the skin, which progresses to mottled depigmentation, dermatopathy, and eventually leading to full-blown cutaneous tumors. Other predisposing conditions include basal cell Nevis syndrome or Gorlin-Gorge syndrome, albinism, Bézek's, and Rombo syndromes. Gorlin-Gorge, of course, is an autosomal dominant condition. Now, for small localized basal cell carcinoma, surgical excision with frozen section or wide margin with 4 mm clearance to make sure that the resected margins are clear of tumor is important. If trained surgeons and dermatopathologists are available, Mohs micrographic surgery remains an option for most cutaneous tumors of the eyelid. For larger tumors where the diagnosis may be tricky or needs to be confirmed prior to excision, an incisional biopsy may be performed. Now, in this patient here, as we saw earlier, a large wide resection was done with 4 millimeters margin. A wedge was taken off and a tensile flap was fashioned, and this has healed very well with minimal scarring. Other alternatives include radiation, cryo, and chemo, but one thing that I want to talk about is topical imiquimod, which has shown great results recently, and also the hedgehog inhibitors vesmodegib, which has got recent FDA clearance for the treatment of basal cell carcinoma. Squamous cell carcinoma is another group of tumors which are primarily invasive and that arise from the squamous cell layer of the epidermis. The most common location is the lower lid, followed by the medial canthus, the upper lid, and the lateral canthus. Lymph node metastasis is seen in up to 20% of the cases, which is why it's important to check the preauricular lymph nodes, which then drain into the submental, the submandibular, and the anterior cervical lymph nodes. So lymph node assessment and identifying enlarged lymph nodes forms an important part of any tumor evaluation. Two conditions, actinic keratosis and keratoacanthoma, are commonly seen in the Indian population, which also are predisposing conditions for squamous cell carcinomas. Actinic keratosis or solar keratosis are seen like these, primarily because of excessive sun exposure. They are rough, dry, scaly patches which may even eventually ulcerate. There can be multiple lesions which then coalesce to form a large lesion. The treatment of these is typically excision or topical 5-FU. They're common on the scalp, ears, the forehead, and the back of hands, typically areas that are exposed to the skin, to the sun. Keratoacanthoma, this is a rapidly growing variant of actinic keratosis, where typically as it grows, you see a central excavation where after involution, there is a keratin-filled crater. And this can eventually grow into a squamous cell carcinoma, most commonly seen in patients with immunosuppressive therapy. It also has associations with Muir-Torre syndrome and Ferguson-Smith syndrome, another autosomal condition where multiple keratoacanthomas are seen. Excision is the most preferred treatment for these. Again, they have a variety of clinical and and histopathological variants, the most common being nodular, ulcerative, and the cutaneous horn form. Now, in an ulcerated lesion, you typically have everted borders with red or well-defined bays. As was the case with basal cell carcinoma, the clinical features can overlap. Now, in this patient, you can see clearly well-defined margins. There is a thickened base. There is sloughing off, ulceration that is also seen in the center. It's close to the medial canthus over here. The treatment in this case, of course, was excision. The entire tissue with a 5 mm margin was taken, and that was replaced with a graft, a skin that was sutured over here. And this is at 1 year follow-up. You can see that the graft has taken up well, and there is no recurrence of tumor in this area. In this case, you need a pathologist to tell you if there is perineural spread. This is typically seen more commonly in squamous cell followed by basal cell carcinomas, which if present, there is a high risk of metastasis. Surgical excision with clear margins is the treatment of choice. The next tumor I talk about is something that my teacher, Dr. Santosh Honavar, typically describes in his presentations with a similar picture of a wolf in sheep's clothing. And the reason for that is because it has so many masquerades that it can present as. Sebaceous gland carcinoma. This is a tumor that almost every ophthalmologist in India would have seen at least once during their practice. These tumors typically arise from all the sebum producing glands or the sebaceous glands, which includes the meibomian glands, the glands of Zeiss, or even the sebaceous glands on the caruncle. Given that these glands are more numerous on the upper lid, we'd expect them to be seen more commonly on the upper lid as well. They can mimic blepharitis with ulcerative lesions, which are typically the diffuse form, or it can be a discrete nodular variant like a chalazion or a lid marginal tumor. The nodular type is hard, painless, and it's like an immobile nodule, which is similar to chalazion, whereas the diffuse or a spreading type can be seen with thickened lid margin, loss of lashes, similar to chronic blepharitis. And it can also have pagetoid spread onto the conjunctiva. And these things need to be identified at the time of clinical evaluation. If not treated in time, they can have very high mortality rate. So sebaceous gland tumors rarely can progress from sebaceous gland hyperplasia, adenoma of the sebaceous glands. What are the features that indicate that there could be an adverse prognostic feature is typically if the size is larger than 10 mm, as you can see in this type. Upper lid involvement or a duration of symptom more than 6 months are also red flags that you should be wary about. It is believed that sebaceous gland carcinomas that arise from the gland of Zeiss have a more favorable prognosis. So the pathology of SGC is important to know, and which is why a pathologist is someone who plays a very important role in the management of these diseases. They are the ones that need to tell you if there is pagetoid spread. Now, they don't need to tell you if there is localized pagetoid spread. Pagetoid spread needs, when we talk about pagetoid spread, we mean skip lesions, especially in the conjunctiva or the ocular surface. Other things that the pathologist needs to tell you is perineural invasion, perivascular spread. These are the 4 typical histopathological patterns that are seen. Now, this is an elderly lady with something that looks very suspicious of a sebaceous gland tumor. And let us look at the features that make it a sebaceous gland tumor. A yellowish nodular component here. The yellowish is because of the sebaceous glands, the sebum content within it. There is localized early ulceration. You can see that. There is localized telangiectasia, prominent blood vessels seen all over this. There is a rounding of the posterior edge or the posterior lid margin. There is loss of lashes, which should have been over here. So given that you put all these features together with posterior lid rounding or posterior margin of the lid rounding, focalized nodular yellowish lesions, telangiectasia, loss of lashes, and ulceration, all of these are red flags clinically for you to suspect a nodular sebaceous gland carcinoma. When not sure, you should go in and perform an incisional biopsy. A map biopsy is not indicated in all lesions, especially not discrete nodular variants. In diffuse lesions, you may want to do a map biopsy, which typically includes conjunctival bits from 17 sites shown over here, which need to be numbered and sent on Wattmann's filter paper, and the pathologist should immediately be able to process them and tell you which sites are involved, based on which then the treatment is performed. Now, surgical biopsy, surgical excision is the treatment of choice. Wide margins, typically with 4 to 5 mm of clear tissue is needed. Now, in this case here again, we did a wide excision to make sure that the entire tumor along with 4 to 5 mm of healthy tissue was excised. A large Tenzel's flap was fashioned, and as you can see, the lateral canthus is well formed in this case with minimal scarring on the lower lid. Similarly, here we could do a wide excision. Here there was direct apposition without the need to do a flap or a localized graft. In the presence of conjunctival disease, however, you may have to treat with topical mitomycin C or localized cryotherapy. In rare cases, as the disease advances, it can involve the orbit and orbital tissues, in which case exentration followed by EBRT or external beam radiation therapy may be needed. Now, I need to talk a little bit about neoadjuvant chemotherapy. This is a paper that I was fortunate to co-author with a couple of our speakers in today's session, where we've discussed our cases of extensive orbital disease where the eyelid sebaceous gland carcinoma has involved the orbit or the periorbita, and neoadjuvant systemic chemotherapy in the form of 5-FU and cisplatin was given. These are 3 patients from the series of 10 cases that we presented. Before chemotherapy at presentation, followed by chemotherapy, the tumor has shrunk. This is another patient where the tumor was adherent to the periosteum, and following 3 cycles of neoadjuvant chemotherapy, there was literally no residual tumor. Similarly, here, extensive disease adherent to the periosteum, and then following neoadjuvant chemotherapy, complete resolution. Of course, chemotherapy treatment doesn't end with chemotherapy. You need to excise the tissue with the same principles of trying to keep tumor-free margins, and a pathologist will tell you if there is any residual tissue. And this is shown to have good outcomes. So proper staging with the help of an oncologist and thorough orbital imaging is important before we set out to treat these conditions. Other rare conditions can be Kaposi sarcoma, which is a vascular tumor seen in AIDS. This can be mistaken for a hematoma or a nevus, which is why you need to be cognizant of this and check the patient's HIV status. On histopathology, you would see predominantly spindle cell vascular channels and a few mitotic figures. Now, Merkel cell carcinoma is a very rare tumor. It's a rapidly fast-going tumor, and there are these small nervous tissues, nerve endings, which end in the cellular, with these highly evolved cells called Merkel cell, which is thought to play a role in the epidermal growth. And this Merkel cell carcinoma can affect the upper eyelid frequently. They are seen typically with a red violaceous hue with dilated vascular channels superficially. They can involve the entire upper lid, as was seen in this patient. This patient, in fact, that we treated was only the 3rd documented case from the Indian subcontinent. So it's a very rare tumor. The overlying skin can also ulcerate in many cases. You can see this is a cross-section of the entire eyelid specimen and a well-demarcated basophilic mass with high number of mitotic figures seen in this. Follow-up is very important because a large number of these patients can metastasize even after the primary has been excised. There is a 2-year mortality rate of nearly 30 to 50%. This was a patient who underwent excision. There was a lid sharing procedure done over here, which is why post-treatment she received radiation not just to the upper lid, but also to the lower lid. We come to the last tumor that I want to talk about, which is malignant melanoma, something that we don't see very commonly in India. There are precursor lesions, a dysplastic nevus, congenital nevus, and lentigo maligna, which we need to be aware of. The most commonly seen in elderly and typically in patients with light skin, which explains why we don't see it commonly in India. Things that we should look for are red flags in a pigmented flat lesion is if it is asymmetric plaque or nodule, which has recently shown growth. If it has got irregular borders, as you can see over here, there is variable colors or variegated appearance within the lesion, which some parts appearing blue and black. If the diameter is wider than 6 millimeters and it is associated with local features of destruction like loss of lashes, all of these would suggest that this could be a potential malignant tumor, which is why we need to have a high clinical suspicion for such lesions. So clinical features of a dysplastic nevi include a nevi which is more than 5 millimeters in size with ill-defined borders and variegated color. These tumors have an increased risk of transformation to melanoma, which is why we should watch them carefully. Wide excision or modified Mohs micrographic surgery is the treatment of option that is advised in the West. We have limited experience with melanomas in India. This was one of the few cases that we came across. Again, a wide excision was performed. The patient is now having 6 years of follow-up with no recurrence. So most eyelid tumors can invade the orbit, which is why I want to keep a couple of slides about advanced eyelid tumors. The most common site of eyelid tumors which can involve the orbit include tumors that arise from the medial canthus, which then may involve the lacrimal apparatus as well. These tumors that involve the orbit have a high chance of recurrence and perineural or distant metastatic spread. So signs of orbital invasion include motility reduction, proptosis, adherence of the tumor to the periosteum leading to mechanical ectropion in the lower lid. In the upper lid, severe ptosis can be seen because of the mechanical component. There could be a gross orbital mass that is visualized and fixity to the orbital structures of the rim, like I mentioned. With that, I'd like to end this presentation and thank the Sankara Academy of Vision once again for this opportunity. Thank you.
Thank you very much, Dr. Akshay. It's been a wonderful talk, and I especially like the way you presented it for the markings, especially the highlighted points for the postgraduates. I'm sure they'll be really benefiting with this talk of yours. And I'd like to invite Dr. Shruthi Tara, who is the Chief Medical Officer and a very senior oculoplastic surgeon attached with Sankara Hospital at Coimbatore. And she'll be talking to us about orbital tumors, both benign and malignant. Over to you, Dr. Shruthi Tara. And in case anybody has any questions to ask Dr. Akshay or anybody else, or even Dr. Shruthi, please post your questions in the YouTube channel and we'll be answering them subsequently after all the sessions are done. Thank you.
Shall we start?
Yes.
A very good morning to you all. I'm Dr. Shruthi from Sankara Hospital in Coimbatore. I thank Sankara Academy of Vision for having me a part of this wonderful program. In the next couple of minutes, let us go through the proptosis and the working diagnosis towards a patient who presents to us with proptosis. Okay, right. So when we are seeing when a patient so when a patient comes to us with proptosis, it is mandatory to know whether it is a true proptosis or is it an exophthalmos. So what is an exophthalmos? It is a term used when there is a prominence of the eye in patients with thyroid-related orbitopathy. What is pseudoproptosis? There are a couple of conditions that we need to know whether it is a proptosis or a pseudoproptosis. If it is a unilateral eyelid retraction, a contralateral ptosis, unilateral myopia, contralateral microphthalmos, and facial asymmetry, they are the causes for a pseudoproptosis. So we should not confuse them with proptosis. So when a patient walks into our OPD with proptosis, there are certain things that should cross our mind, like what is the age of the patient? Is it a congenital or an acquired proptosis? Is it axial or non-axial? Is it unilateral or bilateral? Is it associated with pain? Is the onset acute or chronic? Is it constant or intermittent? Is there any visual disturbances associated with it? Is it pulsatile or non-pulsatile? Is there any positional variation? Or if there is any associated systemic conditions? If we are able to categorize each of this in a patient, most likely that we will come to some kind of a working diagnosis in the end. So we all know imaging is the end diagnosis and the factor for a patient with proptosis, but we should also couple it with appropriate laboratory studies and correlate it with the clinical patient. So complete blood count, peripheral smear, ESR, C-reactive protein, ANA, ANCA, rheumatoid factor, ACE are all the ones, especially when a patient comes with a non-specific orbital inflammation or in certain other causes as well. Now, when we look at the time of onset, teratoma is usually present at birth. Sometimes even dermoid and capillary hemangioma can present by birth. We know lymphangioma, optic nerve glioma, rhabdomyosarcoma, retinoblastoma are all childhood tumors. Those that become apparent in childhood is a lacrimal gland tumor and metastasis. Lymphoma, pleomorphic adenoma, cavernous hemangioma, neurilemoma, or a solitary fibrous tumor are all adult tumors. So, like, for example, this child presented to us when he was 2 months old with an intermittent proptosis. It was exaggerated by an upper respiratory tract infection. And on examination, we found a vascular lesion on the palate. So when we did an MRI, we could see this, a fluid level. So this is invariably a venolympangioma. This was the post-op appearance after injecting with a bleomycin injection. Likewise, another patient with a congenital cystic eye. So they present with a cyst within the orbit. You can see remodeling of the bone here. But this can also be a presenting feature in a patient with teratoma. But of course, I will not be as quiet as this. So that would be a differential. Rhabdomyosarcoma is another childhood tumor where 70% of them occur in the first decade. They present with proptosis, eyelid swelling, and conjunctival chemosis, which is rapidly progressive. And most often times it is in the superior or the superior nasal quadrant. And this is a mesenchymal in origin tumor. So a child who presents with bilateral raccoon eyes, the first diagnosis would be a neuroblastoma. They present with strabismus sometimes, and there could be a restricted ocular motility, and there can be an ipsilateral Honors syndrome if there is a thoracic neuroblastoma. So we should look for it. There are certain tumors which regresses over time, like a capillary hemangioma, which are present at birth and slowly over time, or manifests a couple of months after birth, and it progresses initially, and over time it regresses. So now in a patient with proptosis when the patient presents with proptosis, now we have to see whether it is an axial or a non-axial proptosis. So now if we look into, let us go by a case study. A middle-aged lady presented with proptosis, which was axial, which was gradual in progress for the last 2 years, relatively painless. There was some amount of blurring or hazy vision for the last 6 months, and she did have a relative afferent pupillary defect of grade 1. Color vision was abnormal. There was a mild temporal pallor, and there was some resistance to retropulsion. Now, what are the possible diagnoses? These are the tumors which are axial in nature. So this could be a cavernous hemangioma. This could also be a meningioma, considering the fact that she had relative afferent pupillary defect, color vision, and all that, and the age. But optic nerve glioma is ruled out because it is a childhood tumor. So also the orbital varix, because there was no positional variation. Intraconal schwannoma is rare, can be considered. Thyroid-related orbitopathy, metastasis, all are relatively rare because thyroid-related orbitopathy most likely will be bilateral, and there will be some kind of inflammation. Metastasis also will show inflammation. Lymphoma also will have some low grade of inflammation. So our diagnosis boils down to cavernous hemangioma or a meningioma. That is the optic nerve sheath meningioma. And when we did an MRI, this was the feature. It was a well encapsulated tumor with patchy enhancement. So that goes more in favor of a cavernous hemangioma. So what are the other axial tumors? As we said, the common ones are the optic nerve glioma in the childhood, but in the later phase, it can go into the temporal or inferior dystopia can happen. Meningioma, that is optic nerve sheath meningioma, cavernous hemangioma, and varix. So in the childhood tumor, if it is present in the childhood, then it could probably be a optic nerve glioma, which is associated, 30% of it is associated with the neurofibromatosis type 1. The slowly progressive visual loss can be there, and they will have this fusiform attachment, around the optic nerve. But if it is in an adult, and there is a reduced color vision, visual field defects, RAPD, or if there is an optic atrophy or optic disc edema, and a classical triad of painless, slowly progressive vision loss, optic atrophy, or the optociliary shunt. And when you do an imaging, you see this tram track sign. That is, centrally you see the optic nerve, and then the enhancing around the optic nerve in the axial cut, and in the coronal cut it is called the donut sign, then that would go in favor of an optic nerve sheath meningioma. Some tumors are positional, like in orbital varix. You can see that there is a dilated vessel here, starting from the anteriorly and going all the way up to the apex. So that would, and also if the patient is put in prone position, the proptosis increases. That would be an orbital varix. And later on, sometimes in a long-standing case, they would even be, if the patient in sitting position, would go in for an enophthalmos. That is probably because of the fat atrophy that happens. Let us go into the non-axial proptosis. Another case scenario in a middle-aged lady where there is a medial displacement. So there must be something laterally which is pushing it medially. No pain, diplopia on abduction. There is resistance to retropulsion, no visual loss, long-standing, slowly progressive, and she did not have any weight loss. So what would be it could probably be a lacrimal gland tumor because it is medially displaced. Lacrimal gland is laterally present. So there could be a lacrimal gland tumor which is pushing the orbit medially. So likewise, if it is a downward displacement, it would be something from the frontal sinus. It could also be a schwannoma or a solitary fibrous tumor. If it is an upward displaced, it should be somewhere from the maxillary sinus. If it is laterally displaced, it could be from the ethmoid sinus. It could be ethmoid mucocele, lacrimal sac tumor, or nasopharyngeal tumors. So subperiosteal abscess, metastasis, dermoid cysts are also cause non-axial proptosis. So likewise, if you see a similar condition in a relatively younger patient, our diagnosis would be slightly different. So you can see that there is bony irregularity. That means there is something to do with the bone has been a moth-eaten appearance in the bone. And also, but this is also from the lacrimal gland. You can see that. So that would be a adenocystic carcinoma. And they present usually with some kind of pain and tingling sensation. So that could be a perineural invasion. So if it is an adult and if it is benign, it would be a pleomorphic adenoma. And adenocystic carcinoma would be in a younger patient. So what about the globe displacements? Now it is related to the location like I told you. Intraconal most likely would be a cavernous hemangioma, glioma in the initial stages. Lacrimal gland tumors will be downward and medially displaced. Maxillary tumors will be upward displaced. Likewise, ethmoid laterally, and frontal tumors would displace the globe downwards. So another case scenario in a middle-aged lady with proptosis, long-standing duration again, non-axial, downward and medially displaced. There is no pain, diplopia, and she did have some amount of diplopia and motility disturbance. So this could be a lacrimal gland tumor. It could be a frontal sinus mucocele. There was some kind of a patchy enhancement, so it could be a cavernous hemangioma. Dermoid unlikely because there is no no cyst there. So it could be a neurogenic tumor. So in this case, it was a schwannoma. So, and the diagnosis when we did a lateral orbitotomy and removed the tumor, it was a schwannoma. Another case of schwannoma. So you can see that it is most likely from the superior orbit and pushes the globe downwards. So based on the origin, if we classify, nerve sheath will be neurolemoma, neurofibroma, or it should be solitary or a plexiform neurofibroma. Vascular tumor would be capillary hemangioma, cavernous hemangioma, hematoma, hemangiopericytoma, or a lymphangioma. Neuroepithelial is usually optic nerve glioma. Meningioma is meningothelial. Rhabdomyosarcoma, lipoma, liposarcomal, or mesenchymal. Osseous and cartilaginous would be osteoma, osteogenic sarcoma, chondroma, chondrosarcoma, fibrous dysplasia, and aneurysmal bone cyst. So again, unilateral versus bilateral. Vaginous granulomatosis, histiocytosis, fungal granuloma, lymphoma, leukemia, neuroblastoma, thyroid-related orbitopathies are most likely bilateral. The rest would fall into unilateral. Now, is it associated with pain or not? It could either be an inflammation or it could be some painful tumor like, as I told you, a lymphoma to a certain extent. And if there is a perineural invasion in adenocystic carcinoma. Now, another case scenario in a middle-aged person with non-axial proptosis, but he had acute pain with history of fever. He did have some amount of motility disturbances. He did have diplopia, obviously, with there is motility disturbance, defective vision. The eye was laterally displaced. There was chemosis, relative afferent pupillary defect, and he was a patient with diabetes. So it could be a sinusitis, mucormycosis, any other fungal sinusitis, metastasis, or orbital cellulitis. So when we imaged him, the CT scan showed, you can see that there is a bowing of the periosteum and there was a subperiosteal abscess. Right, another patient with a subperiosteal abscess. So you can see that there is bowing of the periosteum with an abscess here, and they also would have sinusitis. Here it is the ethmoids and maxillary sinus. And they invariably would present with fever, leukocytosis, and they respond in the early stages to antibiotics. Another case scenario with a patient who presented some features suggestive of orbital cellulitis, and the image you could see this, and this was in the CT scan. You can see the central enhancing lesion. It was a cysticercosis treated with albendazole later on. So, what are the other causes of inflammation? Moderate, minimal inflammation would be neoplasms and lymphoma. Acute would be like what we said, the abscess, or sometimes even a ruptured dermoid cyst. But most likely the dermoid cyst in the initial stages would never rupture. It's again another childhood tumor which is slowly progressive and most likely in the external angular like in this patient, but it can be medial or superior as well. And the skin over the lesion would be mobile and the proptosis would be variable depending on the location. So this patient, another patient of the similar lesion, which is presented with proptosis, there was no pain, but there was a downward displacement of the globe. There was no defective vision. He did have a history of surgery done elsewhere previously, and it was a recurrent lesion. When we did an imaging, it was the same enhancing cyst with remodeling of the bone. You can see that the bone is excavated and remodeling as compared to the other side. And he did have a dermoid cyst on removal. And this was yet another patient with dermoid cyst who sustained trauma, and it was a ruptured dermoid cyst who presented with acute inflammation. So another case scenario in an elderly male with progressive proptosis with an upward displacement of the globe. There was diplopia, there was resistance to retropulsion, the firm mass felt on the lower orbit. You can see that it is here. And dull aching pain, and the clinching point was a subconjunctival Salmon's patch. And if you see the CT scan, you can see that there is a tumor here which is molding the globe, and that is lymphoma. Any tumor which molds the globe, which doesn't indent the globe, would raise a suspicion of a lymphoma. And this was him radiation. These tumors respond well to radiation. So what are the chronic tumors? Proptosis, not tumors, proptosis. Would be thyroid-related orbitopathy, vaginous granulomatosis, lymphoproliferative disorders, sarcoidosis, Erdheim-Chester's, IgG granuloma, xanthogranuloma. So non-specific orbital inflammatory disease is again a condition by exclusion. And this was another patient, and biopsy becomes very important here. And when we did a biopsy, this turned out to be a vaginous granulomatosis. Now, how do you differentiate this from a thyroid-related orbitopathy apart from your clinical signs, lid signs, which are very characteristic features in thyroid-related orbitopathy? It is the CT scan features of the muscle. So if you see in non-specific orbital inflammation or myositis, the tendon is not spared. It is uniformly dilated. Whereas in thyroid-related orbitopathy, tendon is relatively spared. It gives a fusiform appearance of the muscle, and most likely, and called as a Coke bottle sign, and this would be a thyroid-related orbitopathy. Acute orbital inflammations are always painful. Orbital infections, metastatic carcinoma, adenoid cystic carcinoma are relatively painful, whereas cavernous hemangioma, neurilemoma, schwannoma would be relatively painless. So initial progression and later subsiding would be a capillary hemangioma. Like if you go back, pulsating tumor would be a carotid cavernous fistula, neurofibromatosis, or a meningoencephalocele. Intermittent proptosis would be a venolymphangioma or varix. Positional would be again varices. So again, similar patient of intermittent proptosis. You can see the fluid level. It is a venolymphangioma. This is a post-operative appearance after intralesional bleomycin injection. Pulsatile proptosis with history of trauma. We should rule out carotid cavernous fistula. You can see that the superior SOV is dilated, and that would clinch the diagnosis of a carotid cavernous fistula. What about if there is a visual disturbance or not? So tumors that arise from the optic nerve or the meningeal sheath tumor would have some visual disturbance, or any tumors which is compressing on the optic nerve would have visual disturbance. Pupils, likewise, similarly, anything that compresses on the pupil would have some amount of relative afferent pupillary defect, and likewise color vision defect also will be there. Motility disturbances is seen in any tumor that is restrictive. Malignant tumors which is infiltrating the muscle, any tumor that displaces the globe can have motility disturbances. Likewise, we should also be very vigilant if there is a patient has got any ENT related history which is suggestive of sinusitis, stuffy nose, or epistaxis. Like this patient was referred as mucocele and referred for DCR, but palpation did not seem very much like that, and nasal examination becomes very important. He did have a tumor in the nasal cavity and the sinuses as well. So ethmoid mucocele is another condition wherein it can arises from the sinuses, which is which can push the globe. If it is from the medially, it can push the globe laterally, and frontal sinus can push the globe inferiorly. But there is most metastasis causes proptosis, but there is one metastasis which causes enophthalmos, and that is the serous carcinoma of the breast. So we should ask the patient if there is any history of breast carcinomas. Sebaceous gland carcinoma, especially medially, can invade the orbit and go behind and cause proptosis. So this was a patient, we did exentration in one such case. So this particular picture, I picked it up from one of my friends, and I thought this is like really, which is really good. And any tumor, where, as far as the location is concerned, tumor that arises from the medial orbit is mucocele, and for any tumors from the ethmoid sinus. Lacrimal fossa lesions would be pleomorphic adenoma or an adenocystic carcinoma. Inferior lesions would be from the maxillary sinus. Superior anterior lesions would be dermoid cyst or a lymphoma. And superior lesion would be from the would be a schwannoma. Likewise, if it is a posterior orbit or the orbital apex or involving the optic nerve, is a meningioma or a glioma. And intraconal would be a cavernous hemangioma. Extraconal would be a rhabdomyosarcoma. So it is very important to take a medical history in patients, relevant medical history like associated with neurofibromatosis, systemic lymphomas, diabetes, tuberculosis, thyroid, if there's any prior surgery for tumors or any radiation given. External ocular examination is invaluable. It has to be very, very, you should be very vigilant in taking the, in doing an external ocular examination. Likewise, palpation, auscultation to rule out carotid cavernous fistula because it is a pulsating proptosis, exophthalmometry, slit lamp examination, and fundus examination is very, very important. Likewise, systemic evaluation as well. So that completes the coming to a diagnosis in a patient with proptosis. Thank you very much.
Thank you very much, Dr. Shruthi. It's been a very nice talk. When we were planning how to go about with it, Dr. Shruthi suggested that we might as well design it for the postgraduates, especially when they need to talk about how they need to come to a diagnosis, and then subsequently how to plan about for the specific proptosis, whichever it is. So those pictures are very nice, which actually showed the zonal or the location-wise tumors. Very important. Please remember the basic ones at least, because that's what the examiner is going to ask you in the exam. Now, the third part of our talk is going to be like something different. This is something that is not dealt very commonly in most of the ocular oncology sessions and the tumor sessions, where we talk mostly as clinicians and as surgeons as to what we're going to operate or what medicines we're going to give. But the most important part that we tend to forget is what happens, how do we rehabilitate patients in whom we've done everything? Like it's been a malignant tumor, gone to the orbit, we've got to remove everything, either the eyeball or accentrated. And how do we rehabilitate them for their life? They have to go ahead with life. So the most important part, which the Ocularis does, is actually designing the ocular prosthesis, whether it's facial or whether it's ocular prosthesis. And now I'll hand over the stage to Mrs. Sukanya, who is our ocularist attached with Shankara Hospital at Bangalore, who will talk about the advantages of having a custom designed prosthesis and also the various types of them. Over to you, Sukanya.
Hello everyone, myself Sukanya Suresh. I'm working as an ocularist in Shankara Hospital. So today we'll be discussing about the topic ocular prosthesis. Let's go back into the history and see. In ocular prosthesis, they have all found in 2900 to 2800 BC. At that time, they have found in a buried dead body. So probably they are assuming that this prosthesis have been made by bitumen paste and a thin layer of gold. And in 500 BC, Egyptians and Roman priests have made prostheses which can be worn outside the socket. And they have made with painted clay which is attached to a cloth. So this kind of prostheses at that time they have called egblepharon. And at that time they had a belief that when they bury a body with artificial eyes, so when the soul goes to heaven, then they can see it properly. So at that time they had a belief like that. And in the 16th century, Frenchman Ambroise Paré have introduced an artificial eye, which is attached to a metal rod. So this one also was worn outside the socket, but like a spectacle temple, a metal rod was attached and it goes behind the head and set. And this one was also made by gold, silver, and other enamels. And in the 17th century, Venetian glass blowers have made glass eyes. So the disadvantage of the glass eye is they are very fragile and easily broken. So this is how they used to make glass eye. Still, this is available in Germany and other European countries. So they melt the glass and then they blow, and according to the size and color they prepare, and then they trim off whatever the size which is needed. And in the 20th century, they have introduced a material, medical grade PMMA, which is polymethyl methacrylate. So currently, right now also we are using PMMA material only. The advantages of PMMA material is the density of the material, the longevity. Since it's medical grade PMMA, the tissue tolerance is very high, and moldability, like whatever shape we want, size, according to that we can mold the material. Let's go into and see different types of ocular prosthesis. So this one is a ready-made prosthesis. So here you can see different types of sizes. This is ready-made one. So if the patient cannot afford a customized prosthesis, then they will go for this ready-made prosthesis. So here you can see the color differences there with the right eye and the left eye. So we have to inform the patient the cosmetically it will not look great. And this is custom made scleral shell. So compared to the normal artificial eye, the scleral shell thickness is lesser than 1.5 mm. So in the cases of pre-thysical atrophic eye, in those cases, we can keep a scleral prosthesis. So in this patient, he had a pre-thysical. In that case, we have made a custom made scleral shell. And this is conformer. So after every socket surgery, we'll be placing a customized a conformer. So once we keep the conformer, after 1 month, once the socket heals completely, then only we'll start keeping artificial eye. And this is iris painted conformer. So if the patient is having a tricycle eye, so first we will give iris painted conformer for 2 to 3 weeks, and then we'll see whether the patient can tolerate the pain, whether the patient is having any discomfort. If they are having any discomfort with the conformer, then we will not proceed with the customized scleral shell. If they are comfortable, then only we'll proceed with the customized. This is pressure conformer. So pressure conformer, what it does is, if the patient is having a congenital anophthalmic socket or microphthalmic socket where we cannot put any kind of artificial eye, in that cases, we keep an customized pressure conformer. So what it does is, it gives pressures for the socket and it will help for socket expansion. So we have to keep increasing the size till we can place an artificial eye. And this is hollow prosthesis. In this video, you can see so right now I'm putting one artificial eye. So because of its weight, it goes and settles down. And now I'm placing hollow prosthesis. So it floats around because of its lightweight property. So we'll create a hollow space in between the shell. And this hollow prosthesis is helpful for the patient who is having enucleated or eviscerated socket without any implant. So at that time, if we are using a normal artificial eye, because of the weight, the lid sag can happen over a period of time. So in that cases, if we keep hollow prosthesis, we can minimize the lid sag. And this is next one is spectacle mounted orbital prosthesis. So in orbital excenteration cases, we can keep a spectacle mounted one. And this is also made of PMMA. This is crutch ocular prosthesis. So here you can see an elevation. So why we use crutch prosthesis? To avoid ptosis. So in this patient had a severe ptosis. So we have prepared a crutch prosthesis. And here you can see we have resolved the ptosis. And next one is silicon orbital prosthesis. Again, in orbital excenteration cases, we can keep a silicon orbital prosthesis and it will attach with the silicon adhesive material. And next goes to custom made ocular prosthesis. These all are few patients which we have seen in our hospital. You can see it will look much more appealing compared to a normal shell. So now let's look into the difference between the stock eye and the custom made prosthesis. So the stock eye, the only advantage is it is inexpensive and it is less time consumable for fitting compared to a custom made. But the disadvantages is ill fitting, improper color match, restricted movements, discharge can be more in that, and restricted wearing period. Here you can see this is the socket and they have kept an artificial eye. So the gap you can see, right? So over a period of time, what happens? The deposits or the tear can accumulate here and cause irritation for the patient. So as well as when we look into the customized, we take the exact socket measurement. So there won't be any space for the deposits to get accumulated. So the discharge will be minimal in this case. And since it goes and fits in all the fornix, the movement also is extended. So when to fit a prosthesis? So in anophthalmic, microphthalmic socket, then as early as possible we can fit the prosthesis, it's good. In post evisceration enucleation cases, we'll wait for 6 to 8 weeks. In post graft cases, since the socket will take more time to heal, we'll wait for 8 to 12 weeks. In deepening of fornix and tarsography cases, we'll wait for 2 to 3 weeks. And in any socket infection cases, we'll wait for 2 to 3 weeks. So what is the ideal socket for prosthesis placement? So the implant should be centrally placed, well covered with adequate fornix space, and the conjunctiva should be healthy, and eyelid should be in normal position and appearance and facial symmetry. So factors to be considered while fitting a prosthesis in tricycle eye. So we have to see whether the patient is having a painful or painless eye. In this case, the patient had severe corneal sensation and severe conjunctival congestion also. So henceforth, we will not be able to fit a scleral shell. And then we have to see whether the patient is having adequate phonic space or not. In this case, we had good space, so we could get this kind of fitting. And we have to see whether the socket size is same or not. So in this case, you can see his socket size is comparatively bigger to his left eye. So we have to inform the patient, even if the patient is preferring for an artificial eye, then we can tell him that this will look bigger compared to his normal eye. In that cases, actually we can put a minus lens, so it will minimize the minimize the size. So now let's move on to the fabrication of ocular prosthesis. So the fabrication, first we have to preparation for the patient. So these are impression molds. We'll get it in different sizes, and according to the socket size we'll select, and through these pores we will inject a material called alginate. So here you can see the patient should be in supine position, and we have inserted one impression mold according to his socket size. And next is taking the impression. So we'll be using a material called alginate, that it is like a paste consistency. We have to pour it inside the impression mold, and it will go and take the socket measurement. So the setting time of the alginate is 2 to 3 minutes. Once it settles, we can take it out, and then we'll get an impression mold like this. So here you can see this is the exact socket measurement of the patient. Next, we will prepare a wax mold according to the impression alginate mold which we have made. And then we will see whether the iris is centrally placed or not, and the size is correct. Then after that, we'll prepare a white base PMMA with polymerization under 110 degrees Celsius. And then we'll get a white base, and over that we'll paint the iris and sclera. So we'll be using color pigments and nylon thread for blood vessels. Once the coloring painting of the shell is done, then again we will do polymerization, and then we'll make this clear coating, and then we will trim and polish the shell, and then after that we will do the final fitting. And at that time, final fitting, if any alteration is required, we can do. And then we'll call the patient for a follow-up after 1 month and see whether the shell is fine, whether the socket is normal. And this is the insertion and removal of ocular prosthesis. We can use a suction cup. So while inserting, the patient has to look down, and then we'll insert the prosthesis. And while removing, the patient has to look up, and then we'll remove the prosthesis. So now let's look into the complication of ocular prosthesis. So the common complications are discharge, dry eyes, and discomfort. So for all these problems, we will be giving lubricant eye drops for them to use. And if we have fit a smaller size prosthesis, rotation or falling of prosthesis can happen. If it is a larger size prosthesis, then lag of thalamus can happen. And if it is a larger size prosthesis, again, lid sag can happen because of the weight. And if it is improper polishing and finishing of the prosthesis, here you can see the polishing is not proper here. And this one, over a period of time, we have done these blue color is like the deposits. So if it is there, then again the patient has to come for cleaning and polishing. And implant exposure can happen if it very rarely if it is improper polishing and finishing. So thank you.
Thank you very much, Mrs. Sukanya. It's been a nice talk. This is something that we don't hear most of the times in most of our clinical discussions. But rehabilitation of patients with empty socket is very, very important. It can make or break the patient's life at times. So with this, we actually conclude our session. We've had a wonderful discussion. At the beginning, we had Dr. Akshay talk about lid tumors, lid malignancies, both benign and malignant, and their management. And what he specified on was actually on the neoadjuvant treatment, which is actually now gaining much more importance. And it's also changing the management patterns per se of patients with lid malignancies. And those ending with horrible exentrations is also reduced. And then we had Dr. Shruthi who spoke about how to evaluate a patient with proptosis and what are the signs in which you can actually localize, whether it's a benign or malignant, or whether it's a location-wise tumors, and how to go about with investigating them and looking at them. And then we had Mrs. Sukanya, who actually briefed about and gave an overview of prosthesis and how to make them. And that definitely we can make a difference in patients' lives, even after removing the eyeball and also the sockets. So thank you all, and I hope all of you benefited as much as I did, and I enjoyed everybody's talk. Wonderful session and very educative. I'm sure each and every one of you listening to this will definitely benefit out of this. Thank you once again, and wonderful day from Sankara Academy of Vision. Goodbye.